In this lecture, Dr. Robert Cywes discusses the role of carbohydrate addiction in driving hunger and causing morbid obesity in children. And he comes up with some really interesting ways of managing this condition in children. Ideas that I've not heard from anyone else.
So, I've been treating carbohydrate addiction for 15 years, and I didn't work this out. My patients taught this to me. In America, it's like a salmon swimming upstream, getting knocked back every time, because the surgeons I work for, or I work with, the ASMBS, they absolutely hate me because I advocate an LCHF, which is a low-carb, healthy fat diet, and not diet and exercise. The bariatricians, when I walked into the room the other day, someone wrinkled their nose. You do surgery? Because I do surgery on fluffy little kids. How can you do that? But the greatest challenge for me is I hate myself because at every turn, somebody's telling me I'm wrong, it's malpractice, it's unethical, and it's so difficult to stand up and go to work every day with that burden on my shoulders, and yet every day I walk into my office, every patient I see reinforces that I'm right. And I've tried for 15 years to disprove myself, and I haven't. Quite the opposite. Okay. One of the greatest challenges, given all of that, is this. The great American philosopher, Stephen Colbert, I don't know if you know him in South Africa, but he coined this phrase called truthiness. And truthiness is the truth that comes from our gut. It is that intense religious belief, and you know how religious beliefs are indoctrinated, that what we believe in is right, and any facts can be disregarded or distorted, and we ignore the facts in order to support our truthiness. And this is the greatest challenge for us in this room, is to get people to look at facts rather than what we call truthiness. This conference is about data and facts. It really is, and a lot of that has been promulgated so far. However, if you think about the physicians in the room, what you do, Western medicine focuses on treating diseases with medication. But if we do not understand the cause and the pathway of such diseases, all we're really doing is slowing down inevitable outcomes. Before we can study outcomes, we need to understand causes. To understand etiology, we need to abandon the truthiness of our assumptions and radically change our understanding of pathophysiology. In the talk I gave yesterday and the talk I'm giving today, I'm going to tell a story. It's based on fact. You can challenge me on anything I say, and I'll give you the factual basis for it, but it will hopefully allow us to understand and treat our patients better. A couple of facts. Almost nobody dies of being fat. Very few people fall over and they're so fat they can't breathe and they die. It is impossible to get fat from eating food. But fat is an essential food, and that's a dichotomy. It's impossible to be heavy and healthy. All because you're not heavy, it does not mean you are healthy. A lot of skinny people have chronic non-communicable diseases. Obesity is not about consuming excess calories, but being overweight is. Just so happens that the calories you consume are in the form of carbohydrates. Calorie-reducing diets and exercise do reduce weight, but they do not treat obesity. So what is the most prevalent chronic illness in America? And it's just a couple of years old. Because only on June the 16th of 2013 did the AMA officially recognize obesity as a disease. And on that day, obesity became the commonest serious chronic illness in America. And we haven't got a clue how to deal with it. We really don't. Because obesity is really not the problem. As I said, if you're fat, your knees may hurt a little bit. Yeah, that's someone's knee. Or you may not look so good in the thong. But other than that, it doesn't kill you. In fact, if you look at the top leading causes of death in the world, ischemic heart disease, stroke, diabetes, they're on there. But obesity is not. And in fact, the top 4 or 5, stroke, heart disease, respiratory infection, COPD, airway malignancy, those are all a residual effect of smoking, which was the commonest addiction that we had for the last probably 80 years. Now, smoking rates are declining, but a similar spectrum of disease, ischemic heart disease, stroke, and diabetes are taking over, not because of obesity, but because of carbohydrates. Okay? The other big issue is this. The average fat person dies at the age of 56. Average American lives to 78. So that's a huge discrepancy in mortality. And if our kids are getting fat younger and younger, that number is going to come down rather than go up. And when it comes to childhood obesity, this is actually a slide I've been showing since about 2001, 2002, and I didn't change this. Those were projections. And those projections are real. I was desperately hoping and praying that those would come down. They haven't. They're actually higher than that. Okay. Obese kids become obese adults. Don't ever think that my fluffy little child is going to outgrow his... no. Very, very unlikely to happen. Fat child becomes a fat adult. But the diseases that they develop in adolescence and in childhood go with them. So that they have those diseases not when they're 50, 60, but now 30 and 40 and 20, 30, 40. Okay. This is such a bad table for us to use with kids. This is the BMI table. We've had a lot of criticism of the BMI table, but if you look at a normal BMI, 20 to 25, that's an adult criteria, okay? But look at this. These are the tables we should be using. A child of 10 years old, okay, with a BMI of 25 is morbidly obese. So we've got to recalibrate when we're dealing with children to use these CDC tables rather than using BMI charts. Now, if you look at, I'm going to show you the next slide, but if you look at my next slide, all of the patients in the study that Jennifer Richards, who was my master's student, she's here in the audience, did, all of my patients are up here. See, can you guys see up in the roof somewhere? That's where my kids are. Not a single patient in the study I'm about to show you fit on these graphs. Okay? Because if you look at this, this is a study of 110 kids we did, ages 10 to 20. Mean age is 16 years. Look at their BMI, and this is on the adult table. BMI of 46.1. Okay? Those are big kids. These aren't fluffy little children. Okay? You can see the spectrum over there. All right. And what we looked at is we looked at comorbidities because in the US, comorbidities in children are disregarded. How can a 5-year-old or a 10-year-old have problems from their obesity? Not possible. Okay? So what we did is we looked at the diagnosis in these kids with a BMI 46, the diagnosis that was given to them by their family doctors. So by the family doctors, that's history prior to initial evaluation by us, about 12% had hypertension. Why? Because the most doctors out there will use a blood pressure of 140/90, which is the adult criteria, to start diagnosing hypertension. I'm simplifying it a little bit. But a 12-year-old child with a blood pressure of 120/80, which is normal in adults, is already above the 99th percentile for blood pressure at that age group. So we've got to look at that. When we diagnosed those patients, 42% had hypertension by the CDC table criteria. So we're way underdiagnosing them. Same thing for dyslipidemia. 8.2% were tested positive. A lot of the kids weren't even tested. 30%, a third of our kids had dyslipidemia. Okay? And the same thing with type 2 diabetes. 15% were diagnosed with type 2 diabetes. 28% had treatable type 2 diabetes. So you look at the underdiagnosed kids, and these are kids 10 to 20. So conventional diet treatments for all of these kids, and all of our kids, no matter what age they are already experts at failing these programs. Some form of calorie restriction, some form of calorie expenditure. To tell a kid with a BMI of 46 to go for a run is sad and it's debilitating for them. They're on some form, how do I go backwards? They're on some form of antihypertensive therapy and usually, as a first line, a salt-wasting medication. Okay? Lasix, hydrochlorothiazide. They're on fiber and statins to reduce their cholesterol, eat lots of oatmeal. And we manipulate the glycemic index. And then we use hypoglycemic medications to insulin to treat them. So that's what these kids are on. Okay? What the effect is to transiently lower their weight, lower their blood pressure, lower their cholesterol, reduce their blood sugar. And then as it starts to creep back up, we throw more medication at them. We're treating consequence, we're not addressing cause. Is that the effect we physicians desire? Hell no. Okay? We're only fooling ourselves because we're changing the numbers. We really aren't treating the cause of the problem, and these kids are getting sicker and sicker and sicker. There are thousands of weight loss programs out there. Everybody's an expert. That includes surgery, injections, gimmicks, potions, powders, and every one of them has this wonderful scientific explanation. But they're all designed to reduce calorie consumption and increase calorie expenditure. And guess what? Everybody loses weight on a diet, or with surgery, or with one of these gimmicks. But then they fail. Okay? Very, very few people who lose weight on a diet can keep it off for a prolonged period of time. So even if a kid loses 100 pounds, if they're 15 years old, where are they at 18? Where are they at 20? Where are they at 40, at 50, at 90? That's what I care about. Not where they are in the first year or two, because this is a chronic problem. And when they, if they've got prediabetes to type 2 diabetes within 10 years, so a 15-year-old kid is going to be diabetic at 25 years of age. A lot of these kids are on statins, but look how pathetically poorly the statins help them to prevent. What we're really trying to do is to prevent cardiovascular disease. And here's an incredible statistic for me, is that if an adolescent requires 1 antihypertensive in adolescence, they're probably going to be on 3 by the age of 30. Okay? So none of these interventions are changing why we become fat and sick in the first place. So how does that happen if, as I said, it didn't happen from food? And I showed this slide yesterday. As human beings, we are designed to require and eat protein, fat, fiber, vitamins, micronutrients, and electrolytes as our nutrients. Notice carbohydrates aren't on the list because we do not need to ingest carbohydrates. The calories can come from protein, carbohydrates, and fat. And carbohydrates are in brackets there because it is not an essential nutrient, therefore it is not necessarily an essential energy requirement. And the body is incredibly good homeostatically at controlling this. How many people have eaten egg white omelets and things because they're healthier? Okay? In America, that's a huge thing. Egg white is just protein. It's just calories. The nutrients come in the yolk. Oh my God, the cholesterol's too high. Okay? The nutrients are here. The calories are there. But the human body is very unlikely to get you to become ill because homeostasis prevents harm. It is anti-species to break this down. In other words, survival of the fittest does not allow this mechanism to cause us harm. It's just the way it is. Okay. The other system that we do have to have, because this manages our mental capacity to think, to focus, to deal with stress, to deal with a lot of what life throws at us, is the endorphin system. And the best way to do it is to have a variety of different endorphin-releasing mechanisms. Now, for healthy people, they can have a beer from time to time. They can have a little bit of carbohydrate from time to time as one of these arms, as long as they've also got action-oriented, internally generated mechanisms to make you feel good. If you play the guitar, if you go to church, if you go for a run, you have a beer every now and then, that's a good diversity. Okay? So the endorphin system is critical, but once you start using carbohydrates, tobacco, alcohol as your primary endorphin releasing mechanism, and you do this in a dominant fashion over time, bad things happen. The other thing to be able to distinguish, and this is where there's a lot of confusion in the bariatric world, and even in the conference that we've had today, is this. It is absolutely true that the insulin-like hormones, glucagon, peptide, ghrelin, Eagle's receptors, vagus, leptins, all of these things govern the thirst and the hunger center. That is their biological mechanism. But they don't cover carbohydrates. Carbohydrates are not regulated by this system, they're regulated by this system. When we go back to eating for hunger, these systems play a role. But when we're doing drugs, and all 3 of these are drugs, it's regulated by this system. And once we understand that concept, it helps us to distinguish between what's a food and what's a drug. Nobody's out there is going to say alcohol is a food source. Okay? But we do that with carbohydrates. So once you understand, once we wrap our heads around these 2 differences and we draw a line of separation here, then we can come to a better understanding of what the physiologic mechanisms are. This is a fat person. A fat person is somebody who uses carbohydrates and snacking as their primary mechanism of emotional handling. And it could be a bunch of these. In the old days, it was drinking and alcohol. It's been smoking. It may become drugs again if they legalize marijuana in our country. What you're doing is you're doing 3 things. You're providing easy access of a powerful drug to a vulnerable population. It's got to be all 3. Easy access, ubiquitous availability of carbohydrates, a very powerful drug, and a vulnerable population. Okay. Here's the next idiotic thing that we've done, but we've got to get our heads around this. It is very, very simple to understand, if you look at a fat person, the fatter they are, the more comorbidities or CNCDs they have. And as they lose weight, those CNCDs transiently get better. So it's very, very easy to make the assumption that weight gain causes comorbidities and weight loss resolves comorbidities. That is putting obesity on the causative side. That's truthiness. That's a false belief. In fact, that is just straight plain wrong. Because obesity is associated with those, but it's not causal. Here's the truth. Chronic excessive carbohydrate consumption causes all of these including excess weight. So being fat is a result, not a cause. Diet and exercise does help to reduce weight, but it doesn't fix all of these things. Okay? And it certainly doesn't change our endorphin releasing mechanism. When you alter the carbohydrate consumption, we lose weight and we treat these diseases go away a lot quicker than you lose weight. So when we treat carbohydrate addiction, we ameliorate or put a lot of these diseases into remission. And that's the truth. But we've got to get our heads around that. Okay, so it's difficult to understand this, but let me go progressively through this. Weight gain in CNCDs comes primarily from chronic excessive carbohydrate consumption. I just said that. Weight loss, however, can occur with any form of calorie restriction. The body won't let you get fat if you eat protein and fat, but if you cut out your protein and your fat, you will lose weight because it's a calorie, that is where the calorie balance comes in. Okay? Difficult to get our heads around that, but that's where the people that don't understand this have that argument that it is calories in and calories out, because they don't understand the homeostatic control. So weight loss can occur with any form of calorie restriction. Comorbidity resolution, however, only occurs when you remove the carbohydrates, not the calories. Okay? So weight loss, however, with carbohydrate reduction is very slow. Because homeostatically, your body's going to hold on to that extra fat if you're eating enough calories and enough protein from fat and protein to support your daily needs. Then your body saves its fat for a lean day. So effective weight loss and CNC resolution, effective resolution of all those results of carbohydrate, calories and carbohydrate, the drug, require calorie restriction as well as carbohydrate reduction. Does that make sense? Okay, not just one. And the role of surgery in some of my patients, these kids with BMIs of 46 plus, the role of surgery is as a weight loss tool to help them to be comfortable eating fewer calories than they need, because they've still got to eat the nutrients, the fat, the protein, the fiber, the micronutrients. They still have to eat that for nutritional value. But the 80+% that a normal person eats a day for calorie value, they don't need to eat. They can get that from their fat. But it's very difficult to be under starvation criteria all the time. The surgery helps them to deal with that. So obesity is a substance abuse problem. But in obesity management, we've been obsessed with weight and nutrition. We've ignored the addiction component. 70 to 90% in my practice, when I evaluate what they put in their face before they come and see me, 70 to 90% of an average obese person's total calorie consumption is in the form of carbohydrates. Okay? Which also means that they're not getting enough of the right stuff in, and therefore every fat person I see is also malnourished. However, exercise may reduce weight, but it does not affect cardiovascular harm from carbohydrates. So the problem with a lot of the unseen patients, fat people come to my office, skinny people don't. But a lot of thin people are eating a similar percentage of carbohydrates, and they're exercising off the calories, but this is still happening to them. And that's a bigger concern in our society now. Okay? So if you look at the kids, why do you operate on little babies? This kid over here kicked off a dance squad, hip problems, back problems. A year later, she's a soloist. This guy over here, Cody, one of my early patients, big boy. He has an artificial hip at the age of 15. Okay? A year later, ask me if you can play baseball. Look at this girl. She's on Prozac, she's on lithium, she's on Abilify. Baker Act is where you're legally forced to go into inpatient rehab or psychiatric facility because you're committing suicide. Big cutter. Look at her here. Okay? Off all those medications. Carbohydrates are toxic at ingestion. So now I'm going to take you down. Everybody's presented data and outcomes. I want to give you my view as a surgeon of the story of how carbohydrates work. And this comes back from my PhD days when we looked at liver processing of carbohydrates. So I'm going to tell that story. Okay. Remember this, that chronic excessive carbohydrate consumption leads to disease that may be variably expressed. If you smoke, you may get lung cancer, you may get emphysema. It is expressed in a different way. So it's interesting that some people are extremely fat, but not diabetic, because insulin protects against diabetes. But insulin, as we've heard before, makes you very fat if you're eating a lot of carbohydrates. However, there are a lot of slightly overweight or even normal people who are brittle type 2 diabetics, even though they're not very fat. So how does that work? Here's the way it works. And I'm going to be very simplistic because I'm simple. Every human being has a pancreas that genetically can produce a certain amount of insulin when it's maximally stressed. Okay? So you may have a pancreas that when maximally stressed can only produce a small amount of insulin. Some people may have a huge capacity for insulin. We actually measure this in our office. So when I see a huge person who's not diabetic, you measure their insulin, their C-peptide, it's through the roof. When you see an overweight person who has type 2 diabetes, their insulin is actually very low because their pancreas can't make more. However, if you eat more carbohydrate on a regular chronic basis than the maximum insulin producing capacity of your pancreas, that gap is called type 2 diabetes. So if you've got a huge capacity for insulin production, you may become very fat, but you're not diabetic. If you have a low capacity for insulin production, you may become diabetic with a relatively small carbohydrate consumption. Does that make sense? Okay? So variably expressed patterns of carbohydrate toxicity. But if you don't eat carbohydrates, it's unlikely that you can be a type 2 diabetic. So let's go through the story. And I think this is the other thing that we tend to do is we categorize hypertension and diabetes and high cholesterol as these separate entities. I loved the talk on inflammation the other day because for my PhD, I looked at this. So let's follow carbohydrates as they go into your face. And then the next thing is this. It doesn't matter how it goes in this hole. It doesn't matter if it's an apple, ice cream, chocolates, chips, pasta, bread, rice, cereal. It doesn't matter if it's brown bread, white bread. It doesn't matter how the carbohydrate goes in this hole. By the time it enters your bloodstream, it is glucose, galactose, or fructose. So let's follow that pathway. The first thing that sugar does, and this is the part that nobody's really talked about. We've all talked about insulin, but we haven't talked about the properties of sugar. Sugar is incredibly hygroscopic. In other words, it sucks up water. When you put sugar in your tea, it dissolves, just like salt does. Hygroscopic, so it sucks up water. As soon as that sugar gets into your bloodstream, it sucks up water from your gut. That's why carb-loaded athletes have to drink all the time, okay? So the first thing that happens is your blood pressure goes shooting up because you've got a ton of intravascular volume that you didn't have before. So you get hypertensive, okay? The next thing that happens is sugar very, very quickly, without any help from hormones, enters the endothelial cell. The endothelial cells are the cells that line the blood vessel membranes. And the endothelial cell should look like a fried egg, okay? And it's got a very anticoagulant surface. It's got a whole bunch of properties on the front that are like Teflon that allow blood to slide by. So the first thing that happens is the blood volume increases. That's the hypertensive effect, R to the power 4. Remember that. So you're stretching these, that's the radius of the vessel. So you're narrowing your vessels, you're getting this higher flow. A flat cell doesn't hold a lot of volume. So when the sugar goes into the endothelial cell, it sucks water with it. And when it does that, the cell swells up. So what happens is, instead of being like a fried egg, it turns into a boiled egg. It rounds up. And when it rounds up, it squashes the lumen, R to the power 4 narrows the lumen, and it exposes underlying basement membrane or sinusoidal membrane in the liver. And the sinusoidal membrane or the basement membrane is highly coagulopathic. It's got a lot of molecules, because you don't want that exposure. That's called harm. That's when you cut yourself, that happens. So it's procoagulant. So you initiate the clotting cascade, and you have this intrinsic pathway that starts clotting, and the clotting factors come in, and you've got a lot of expression of the prokinetic molecules. Platelets stick, and that was my work in my PhD thesis. Platelets start to stick to these membranes. They build up a little clot. And the next thing that you've got running around are your small molecule LDLs, and we had that wonderful talk about how oxidative they are. They get trapped in this little collection, and the that oxidation of those molecules creates further inflammation. In come your Kupffer cells or your white cells, and you develop this little clot in the blood vessel. So now you've got a narrow lumen with hypertensive, but you've got this clot that's formed. That means that oxygen can't get downstream, and distally you've got ischemia. So you've got a low blood flow state, you've got an ischemic effect, which damages those cells. That is what diabetes is. Diabetes is an A1C of 6 point something. Diabetes is a vascular problem caused by ischemia downstream. So if you've had a lunch with a lot of carbohydrates, why is the 2 hours after lunch such a bad time for people? Because your brain swells up. That's a concussive effect. You basically concussed yourself. You might as well have gone and played against the Hurricanes last night, like the Blue Bulls, and probably beaten them. No, you got a concussion. And there's distal ischemia in the brain. It doesn't function that well. And then as your sugar levels come down, you can function a little bit better. Same thing happens in the kidneys and the liver. And the place I saw it was in the liver. But 20 years ago, I didn't understand that. So it was truthiness for me, and now I understand it better. So you've got to integrate hypertension, you've got to integrate the diabetogenic effect and the coagulopathic effect, as well as the cholesterol. It all makes sense. And it's initiated by the sugar. Does that make sense? Okay? And this is the net result that we see over there. Okay. So the other thing, we saw the slide yesterday briefly, but I want to go through this again. When you eat sugar, one of the things I also found in my research, and not a lot of people know this, fructose, glucose is a very, very powerful activator of insulin release. Fructose isn't. When I injected fructose into the livers of my patients and my animals, the insulin didn't go up. So what's happening is fructose creates a much, much higher level of circulating sugar in the vascular stream, much more fluid in, much more damage than either glucose or galactose does. So this is by far the most harmful of the three sugars, even if it's just for that reason. Okay? And this is what we put into all our processed foods. So what happens when these sugars go in? A little bit, maybe 500-600 grams goes towards glycogen, which is our rapid response. The rest, the liver is extremely good at converting sugar to fat. That's its job. So it converts the sugar to triglycerides, but when there's an excess, when you overwhelm some of these systems, it starts producing the bad cholesterols, the VLDL and the LDL. So here's the next big concept we have to change our minds around. Bad cholesterol is not consumed. Bad cholesterol is produced by the liver when it converts sugar to fat. So no matter what you do in your GI tract in terms of getting rid of cholesterol, it is totally useless if you're eating carbohydrates, because that's where the bad cholesterol comes from. So you can eat all the oatmeal you want to in a day. It ain't going to fix that. In fact, it's going to make it worse. I'll show you in a second. So if you understand this pathway, you understand that we've got a lot of circulating sugar. We've got the bad cholesterols. We've also got lactate being produced because of the general ischemia. It's a very, very toxic environment. Okay. So here's the next little, I hope this blows your minds a little bit. Fat cells, if you go back to the paleo era, the paleo era is that era where we used to eat and drink what came from the land. It's the pre-farming era. Okay? In my head, it's the pre-farming era. Fat cells are our genetically developed energy reserves. That's where we store energy, and it's stored as fat. Humans are designed to use fat as their main energy source. Human energy balance depends on the ebb and flow of fat to and from the fat cells. During a meal or right after a meal, you load up your fat stores, and after a meal, between meals, I hate the word starvation. Starvation is that period between meals. That's where you start using up the fat from your fat cells. Glucose is not a fuel. Glucose is a nutrient. There are certain systems in the body that require glucose, but it is not designed to be a primary energy source. Okay? Fat is the fuel. Fat is the fuel, but glucose is not. All right? Insulin and glucose, because if you think about it, at the time that the hormone insulin was being genetically developed in our bodies, we didn't have exposure to a lot of sugar. We ate a very, very small, if any, amount of sugar. So genetically, it's not possible that insulin was designed to deal with sugar. Just like lactate dehydrogenase was not designed to deal with alcohol. As a side effect, it processes alcohol. But that wasn't there by design, because we haven't been drinking alcohol for very long. So if you think about it, insulin and glucagon's role is actually to direct energy or fat flow. However, the insulin does direct gluconeogenesis from amino acids. That's why we don't have to eat sugar, because it is very effectively produced from amino acids in the liver. We do need blood sugar. We do need sugar in our bloodstream for the purpose of those little parts of our body that need sugar for nutrient, non-fuel purposes. The only time that sugar is really required or needed is right here. The glycogen in our liver is kind of a first responder energy reserve. It's a little bit like driving your car. You're driving a race car. Your petrol, the gas in your tank, is the primary fuel. But if you suddenly want to go faster, you hit the nitrous tank, and the nitrous tank, which is a very small amount, gets you a little burst of energy. That's what the glucagon on our livers is for, and that's why it made us successful as a species. Okay? But insulin is not designed to regulate glucose consumption. That is post-genetic. But most scientists, you see, here's the way it happened, is insulin was discovered by Dr. Best when he was dealing with diabetes. So the assumption was insulin is there to regulate sugar because it causes type 1 diabetes. And we've just got to rethink that. Now, I don't know this for a fact, but this is what's inside my head. It's swirling around my head, and I'm going to ask you guys to process that, to think about it, and come and tell me that I'm wrong, or show me what the right pathway is. These are just thoughts. There's no science behind this. These are just thoughts that I'm having as I think through things with a minor logic of a surgeon. Okay. If insulin regulates fat metabolism, then insulin regulates cholesterol metabolism. Okay? So when it's consistently elevated, ingested carbohydrates can get converted to what we call the bad fats, and that is an insulin effect. See how it all ties in? So let's take that further. Polycystic ovarian syndrome, PCOS. Okay? PCOS is really an increase in females in progesterone over estrogen. They get a male fat distribution, they lose that curvy female shape, and they become more viscerogenic in terms of their fat. Okay? Progesterone and estrogen are sex steroids. Where do they come from? Cholesterol. Okay? So chronic excessive carbohydrate consumption causes an alteration in insulin-glucagon ratio that blocks cholesterol to estrogen and increases progesterone production. A lot of doctors in the US use metformin as a first-line treatment for PCOS. It's a diabetes drug. So the next thing is this, and a lot of you have to explain this to your patients. Boys and girls will respond to a low carbohydrate diet in a slightly different way at the beginning. Because everybody's got a diet mentality, we're obsessed with losing weight. So the first thing, I didn't lose weight, and they will abandon the low carbohydrate diet because it didn't work, because they didn't lose a lot of weight to begin with. And the boys lose weight quicker than the girls. So let me give you at least my insight into that explanation. When a girl goes low carb, there is a spike in estrogen production because she's gone from being primarily progesterone-driven to being estrogen-driven. And estrogen, we know, Gary Taub showed a beautiful film of a boy and a girl going through puberty. Boys lost fat mass, and the girl gained fat mass. That's an estrogen effect. So what happens is, estrogen is lipogenic, but it is not a harmful fat. So just like at puberty, the girls may paradoxically gain weight because they are increasing their estrogen delivery or their estrogen production, but that fat is redistributed like puberty, so they become a little bit more curvaceous. They lose the visceral fat, and they gain it on their hips, their breasts, the place where girls genetically gain that weight. But that explains why girls may paradoxically not lose a lot of weight or gain weight transiently. After about 3 or 4 months, girls actually lose weight a lot quicker than the boys do because that effect is stabilized, and the boys by that time have lost their rapid weight early, and they start sort of getting to the leveling off phase, whereas the girls are now bouncing down. So I always talk to my patients, my female patients, about this effect before they start. They've got to expect that. The other reason why a lot of my girls, 12% of my adolescents gain weight in the first year of their after surgery. They sit on a warm toilet seat and they get pregnant. Okay. The final thing, when we're talking about the hygroscopic nature of fluids, the human body is designed to use salt and other protons, potassium, magnesium, as its primary hypertension or blood vascular fluid balance system. Sugar is just like salt. It sucks up a lot of fluid. So when you are sugar loaded, the body can't handle the volume, so the first thing it does is it gets rid of salt. So a lot of our patients are actually low in salt because they've got so much sugar in their vessels. They're fluid overloaded, and the body does whatever it can to eliminate the salt. Then they're hypertensive, so we put them on HCTZ or Lasix, and they pee out more salt. So most of our patients are salt deficient, okay? And we've got to understand that salt and potassium are the regulators of water retention. And these systems integrate homeostatically to manage salt and water balance. Sugar retains as much salt as water. So when patients become low sugar on the low carb diet, you want to add salt to them so that they do not become dehydrated. But we want to get back to a place where salt regulates our homeostatic fluid balance, not sugar. And we've gotten away from that in the carbohydrate era. So the American Heart Association recently said salt is fine. But for years, it's been low salt, low salt, low salt. And in fact, if you think about it, the majority of manufactured foods have a very high salt content as well as a very high carbohydrate content. So it's just little thoughts as you go through this. It's not all about carbohydrates, it's about homeostasis. Okay. We've got to understand how erroneous and harmful the glycemic index concept has been to type 2 diabetics. If you understand my addiction model, telling a fat diabetic person to control their sugar consumption, this sugar is good for you, that one's bad for you, is like telling an alcoholic to control their drinking. Drink beer, don't drink whiskey. It's ridiculous. Nobody would ever do that, yet we repetitively do that to our obese patients. Are you managing diabetes or blood sugar? Do statins manage cholesterol? Or are statins supposed to reduce cardiovascular and stroke risk? And how does that work? Okay, so let's go through, and this is a big American concept because we trust Quaker Oats. Quaker Oats tells us helps remove cholesterol, and guess what? They're absolutely right. That statement is 100% correct because fiber absorbs cholesterol in the gut and you poop it out. However, does oatmeal lower blood cholesterol? It removes cholesterol, but does it remove blood cholesterol? Well, what is the cholesterol moiety in the food that we eat? Over 90% of the cholesterol in an egg is HDL. Okay? Something our bodies need and something our body absorbs. So you eat the egg, but now you're eating the oatmeal, the fiber absorbs the HDL over here, and you poop it out. So you're pooping out your good cholesterol. And then the next thing that happens, what is in Quaker Oats? Okay? Weight control, maple and brown sugar. Look at this. Chips Ahoy cookies, 27 grams of total carbohydrates. Strawberries and cream oatmeal, 27 grams of carbohydrates. We already said that bad cholesterol does not come from consumption. There's very little VLDL and LDL in what we eat. It's mostly HDL. But when sugar gets converted to fat, it produces bad cholesterol. So when you eat your oatmeal and you eat your eggs, the oatmeal absorbs the good cholesterol and you poop it out, and this sugar gets converted to bad cholesterol. So when you look at the science behind this, yes, oatmeal absorbs cholesterol in a test tube. But in a human, what happens is patients who eat oatmeal, their weight stays the same or goes up, and patients who eat cholesterol, their cholesterol stays the same or goes up slightly. Okay? But look at how they manufacture their claims. So it's an important concept for us to understand. This is a patient of mine. I know you've seen a lot of this type of thing. 3 months, and this is pre-surgery. Pre-surgery. She was an adult. But look at her cholesterol profile here on Lipitor. Within 3 months, 290, 145, 250, 103 for the triglycerides. HDL stayed about the same, 54, 55. VLDL from 50 to 21. LDL, 185 to 70. Okay? And that's off Lipitor. This is a big concern for me. Okay? Obviously, this is the healthy diet. Look at it. It's fruit, it's oatmeal, it's natural Florida orange juice. That's the healthy breakfast. Oh my God, how the hell can you eat that? You're going to clog your arteries. Get that all the time. That's the oh my God breakfast. 90+% of the calories from carbohydrates, 90+% of the calories from fat and protein. Okay? But a lot of normal people, normal athletes, will eat this breakfast to carb load because that darn guy, Tim Noakes, told us to do it. So one of the big concerns for me, I'm 51 years old. In the last 2 to 3 years, I've lost at least 4 of my friends who are a lot fitter than me. They were going for a run, they dropped dead. It's what I call the Dead Runners Society. Okay? It's a very, very sad thing. But these are the people that are so fit that they cannot be unhealthy. But these are the people that eat this breakfast and then go for a run and burn off the calories. Nobody smokes 3 cigarettes and goes for a run to burn out the nicotine. But with carbohydrates, we do that all the time. The carbohydrates that you eat here may not contribute to your weight because you've burnt off the calories, but at ingestion, as I explained a little bit ago, your blood pressure goes up, you have a diabetogenic effect, you have that distal ischemia, and now you're stressing your body, and at 40, 50, 60 years of age, you have the stroke, you have the heart attack, you die. So this is the unrecognized population. So the best thing to have for breakfast is this calories, then go for your run. Or if it's not a hunger meal time, it's fine not to eat. Breakfast is the least important meal of the day. Okay. So let's go to our study. Those of you that still say surgery, oh, it's bad, it's bad, it's bad. Remember, these are big girls. big kids, 46. By the way, also, it's not just girls. 68 are girls, 42 were males. So a very even distribution of the sexes. But look at this, 3 years after surgery, BMI 46 to 29.8. That's a very, very impressive weight reduction. And it's a combination of the low-carb diet, but for those that were struggling to maintain it, and addicts fall off the wagon. This is primarily a surgical effect. But that's just weight loss. That's just calories down, okay? Let's look at the parameters, and these parameters come primarily because most of these patients followed the low-carbohydrate principles. Did they fall off the wagon? Hell yeah. But my job is to pick them up and get them going again. Look at this. 42% hypertension down to 6.4. Okay? 30% had dyslipidemia, we're down to 16. 28% had diabetes requiring treatment, 8.8 3 years afterwards. So pretty impressive numbers. So this is low carb. The weight loss is primarily surgery. Let's talk about some of the craziness in our organizations, because this is the battleground for us as physicians. This is where we need to be first responders. And this is where a lot of these kids are getting misinformation, so it's not their fault. But I tell my kids all the time, it's not your fault that you became fat, but it is your responsibility to do something about it. Okay? American Academy of Pediatrics. Preschoolers need about 3 servings, half a cup for this age, of fat-free skim milk or low 1% milk. That's on the front page of their website. What do the facts say? And there are 5 studies that look like this. This is not a small study. 10,700 US kids, 2 to 4. 1% skim milk had a higher BMI score than 2% whole milk drinkers. Increased fat content in the type of milk consumed was inversely associated with BMI score. Children drinking 1% skim milk at both 2 and 4 years of age were more likely to become overweight, obese between these time points. That's the fact. The truthiness is they don't care. I talk to pediatricians, I show them this data, and they tell me it's wrong. I can't do this. I can't change from being a Christian to being a Muslim. They just can't change their brand of religion. Okay? Same thing with this. We have to accept the fact, we have to abandon the fact that fat is bad, and that's a very, very difficult thing to do. Okay? Big study over here that showed no correlation, you've seen the study before, between the consumption of saturated fat and heart disease. But everybody will tell you that bread is fine, it's nice brown bread. Oh my God, the butter is terrible. Okay? Blood pressure. I said this before. A child with a blood pressure, a 12-year-old child with a blood pressure of 120/80 is above the 99th percentile, or above the 95th percentile. Here it is, 99th percentile. Okay? So we've got to treat our kids according to the tables, rather than according to adult statistics. But unfortunately, for a lot of this kind of thing, there are no percentile charts for type 2 diabetes. Remember, 30% of my kids had type 2 diabetes, but there are no percentile charts. So I've made a suggestion of starting to treat the patients with a hemoglobin of A1C of 6.0. Yes, it's on the low side, but remember, damage doesn't just start when you are diagnosed as diabetic. Damage starts when your cholesterol, when your carbohydrate consumption goes up and you are stressing this system. So for a child, they need to be treated at a much, much lower point. Obviously, the best treatment is low carbohydrate. But I can tell you this, if a child is forced to stick a needle into their finger 4 times a day, they're very quickly going to find an alternative. They're either not going to do it, or they're going to say, hey, maybe I should come off the carbohydrates. They need that incentive. This is a study looking at hyperlipidemia in kids of patients of adult patients who had heart disease. Look at the amount, the high cholesterol numbers, 52%, 66%, 12%, 57%, okay? Very, very high numbers of bad cholesterol in young kids. However, how do you treat those patients? How do you treat them? We have no algorithm for treating dyslipidemia in children. Okay. 11 years old. Okay. All right, so from a treatment algorithm perspective, yes, absolutely, we want to get these, and this is where science hits reality. And in my practice, I deal in reality with a conceptual understanding of science, as opposed to focusing on the science and trying to deny reality. These kids don't have willpower. They don't have the ability to switch this off very easily. Okay, we've got to understand that. We've got to put this in the real world. Even for a normal person to try to do this, we're going to screw it up many, many times. So, yes, absolutely, the foundation of this pyramid is lifestyle change. It's ideal, but unfortunately, in the real world, it is unrealistic when a child goes to school and they cannot get food that it doesn't contain carbohydrates. When Coca-Cola sponsors our county's school drinking system, okay, think about that. Coca-Cola is the primary sponsor of our schools. The water fountain, at least the drink fountains in our schools, sponsored by Coca-Cola. All right, it's a problem. So we've got to help our kids to divorce their relationship with carbohydrates, and that's very, very difficult when all their friends are eating Big Macs and fries, and that's what they get at school. The physical activity, I hate the word exercise, but physical activity can start to become a part of their lives, not for the calorie burn, but for the endorphin high they get from it. But you really want to do action snacks. I don't care if someone prefers to play the guitar or prefers to take up photography as opposed to running. That's fine. Not every fat person has to be an athlete. Certainly not every skinny person is an athlete. And we work on the cognitive behavioral therapy. But for many, many of my patients, now remember, I'm dealing with the obese or morbidly obese patients. They require, at least initially, some form of medication, some form of temporary device, and possibly even surgery. But these tools are there to help these outlier patients, who are actually, unfortunately, becoming the norm, 25% of our population, these outlier patients, to be successful at changing this. Okay? And if you look at the programs, the results of traditional diet and exercise weight loss, at best, and this is probably an overestimation, 4 to 8%. In our program, we're looking at about a 70% long-term success rate. Okay? Here's another statistic you should know. Now, this is adult criteria, and I'm not a proponent of bariatric surgery, but there is a reality. The naysayers, the people that say absolutely you should never have bariatric surgery, are as harmful to what we do as the people that say that the low-carbohydrate diet is garbage, because they're ignoring the facts. This is a group of patients who went to a seminar, very similar seminar to what we're talking about, obese people, New Haven, Connecticut. And all they did is they divided them into two groups over 5 years. Those that had bariatric surgery, those that had no surgery. And they looked at all comers and all results of morbidity. So it doesn't matter, of mortality. It doesn't matter if you got hit by a car while you were running or you died of a heart attack from your cholesterol problem. The survival in that group that had surgery was 97%. 3 out of 100 died. That group that had no surgery, only 78% were alive after 5 years. 22 out of 100 people died in the 5 years after coming to a seminar. Okay? Average age of death? That's reality. And it's nice to say, yes, you should have the willpower, put down the carbohydrates. Very, very difficult when carbohydrates are ubiquitously available. So, and here's one of the reasons why. The objective of surgery is to reduce calorie consumption. It is not to make you not absorb them. The malabsorptive operations are a big, big problem. I do not believe that gastric bypass is an operation that should be done on a human being because it's malabsorptive. But calorie-reducing diets, calorie-reducing surgeries are good. The problem with human nature is no matter how engaged a person is, they're going to try to preserve or restore the status quo. And when they go back to the carbohydrates, they're going to regain their weight, no matter whether they've had the surgery or not. So while we do surgery, it has to be done in the context of an obesity management program, which is to modify the source of the endorphin release away from a substance toward action. The durability of weight loss, it's just like a very, very powerful diet. It lasts for about 1 to 3 years. Okay? So it's a tool to help you. It's not a magic bullet. And too many of my colleagues have been maligned because they've seen it as a magic bullet. However, what we do have to understand is the durability of what I do to my patients is lifelong. So if I operate on a 15-year-old, the effectiveness of their weight loss is going to last about 18. Hopefully, I've done enough work with them that they've also changed their relationship with carbohydrates and everything else they do that they're able to sustain that weight loss lifelong. But if they're going to live to 78 for the next 60 plus years, they have to live with the consequences of what I've done to them. And therefore, I want my patients to lose weight, but not to transition from the disease of obesity to the disease of malnutrition or other surgical consequences. So we've got to be very selective about how we do the surgery. And unfortunately in America, you guys are luckier in this country than I am in America. America, the FDA has screwed us over time and time and time again by taking very, very useful devices that really have very, very little harm and restricting them. We have not had a device approval by the FDA in America since 2001. And during that time, obesity rates, you've seen the maps gone through the roof in the US. What we're looking at now is a little bit of liberation of that so we can start getting additional things. Now, what am I talking about over here? I'm talking about, this is the surgery, okay? So absolutely no way, certainly not in a child. I'll get a lot of pushback from my bariatric surgery colleagues because this is the best form of weight loss. It's called comfortable starvation. If you can't eat, you're going to lose a lot of weight. But 100% of these patients, the gastric bypass patients, are going to have complications from their surgery. And I hate dealing with them. Sleeve gastrectomy, purely restrictive. Lap band, purely restrictive. These operations are great, but they've been maligned because people regain their weight. Why? Because these are not standalone operations. They have to be done and performed in the context of a low-carb cognitive behavioral therapy program. Average time that my kids from first encounter to surgery, 11 months. 11 months. So those kids are in my program on average for 11 months dealing with their carbohydrate, making those behavioral changes before we ever decide to do surgery. And the best kids are those that do so well in the program that they can keep postponing their surgery. Okay? All right, but these are the, so this is the results of my lap band experience. So this is a different study to what Jennifer produced. Okay? Incredibly good weight loss results. 43 down to 27, 4 years post-op. You know that I couldn't get this work published? It wasn't done in an IRB. It was retrospective data. We don't believe your data. Submitted 3 times, rejected 3 times. Very strong study. But because I said I did it in a low carbohydrate fashion, every surgical journal has rejected the work. Okay. So the objective of the management of weight is to use as a foundation the low-carb cognitive behavioral therapy change. However, the tools that we have at our disposal should be a multimodal therapy. You can have temporary reversible devices, and you can sequentially or additively use them, and you can still do some revisional work. So the objective here is to help people down the road. When you just try the low-carb diet, when you just quit smoking, you do well for a while, you screw up, and you go right back. So the problem with a lot of the diets is this kind of pattern. When you have one of these things done, you engage in the process, you lose the weight, you screw up, you level off, and then we bump you down again. You come in, we manipulate a few things, and we come down. So in our practice, the changes happen in kind of a stair-step fashion, but that is far better than the yo-yo fashion. Okay, so there's a variety of new devices coming on. Neuroregulation, GI space-op and malabsorptive strategies, endoluminal suturing platforms, which I kind of favor, technically challenging, transgastric suturing platforms. I know as a non-surgical audience, you don't know what I'm talking about. It's as simple as a little tablet that you take that expands in the stomach, or the full bar, okay? That works. It works for some people. So you feel full, and when you do eat, you eat a much smaller amount as long as it's low carb. So you've still got to choose the low carb stuff. You've still got to deal with the snacking. But this helps you to eat less. Vagal pacemakers. This is the trial that we're just getting into now. I'm not so certain about this. And look how radical this is. A group in Ohio State are sticking probes into people's brains to modify their endorphin center. And everybody's shaking their head. No, no, no. Okay? And I don't like this personally, but that's a belief, and I've got to get over that. Because while this may seem kind of radical, it's far more radical to die at 25 of a heart attack. Okay, those are being done in adults, not in kids. And again, this is something that's just about to be released in the US. This has been around in this country for 11 years. It's the Obera balloon, the Obalon balloon. These are balloons that get placed in the stomach that just act as space-occupying lesions. So instead of eating a huge amount to feel full, you're eating a much smaller amount. But you've still got to choose the right stuff. You eat ice cream and chips all day long, this ain't going to work. You eat steak and broccoli, it's going to work. Same thing with all of these devices. The point is, I want you to broaden your horizons in terms of the tools available to help your patients to be successful. I find some of these unpalatable. I use some of them. I have discretion. But a lot of it's based on my own beliefs and what I'm capable of doing. But what I don't do is roadblock this. Ultimately, what we really want to be able to do is to focus on carbohydrate restriction and that lifestyle modification. If we have to add some procedures, they should be really minor procedures with very, very low comorbidity, fast recovery time, really not surgical, not cutting people open. And if we have to, we can then go to some of the bigger stuff in a stair step. But you don't want to leave your patient stranded because you don't believe in a certain thing. Okay. So as we go through this, I know that this is a controversial topic for people that are not invested in this. But what we do have to understand is that current treatment strategies are hopelessly ineffective and very tightly regulated. We have to be able to distinguish, and I've tried to do this today, between weight management, nutrition, and obesity management. Okay? We've got to understand that, yes, carbohydrates are an evil, but they're not the only thing. You may be hypertensive from something else. You may have a genetic knockout that causes your cholesterol to go up. Low carb may affect that, but it's not going to cure that. So we've still got to be doctors before we just focus evangelically on this. If we focus evangelically on carbohydrate addiction and carbohydrates as the be-all and end-all, we are doing as much harm to our patients as we do if we ignore carbohydrates. We still have to be doctors. But when you remove carbohydrates from someone's world, those carbohydrates had value. And the value they had is a poor source of nutrition and a poor source of endorphin management. So if you don't help patients to replace both of those with more effective nutrition and more effective endorphin release, they're either going to go back to them or they're going to find something else that's equally harmful. So understand that addiction management philosophy and be able to categorize that. We have to, in our own heads, sort out and distinguish the data from the belief. And yes, I've promoted some of my beliefs. And I've tried to tell you where I don't have science to support what I'm saying, but I'd like you guys to think through that and process through that and hopefully come up with the data to support or reject what I said. Okay? We have to look at three components of obesity. The causative agent, which in my head are the carbohydrates. The access, which is what the companies that produce manufactured food throw at us. They're marketing, they're advertising, everything else. And we've got to understand what makes a vulnerable population. As a society, we have to work against the companies that provide these drugs. We have to work with our individual patients to understand the harm that carbohydrates do. And as parents and as people that interact from a connectivity perspective with other people, we have to understand what makes someone vulnerable to addiction. All three of those. It's not just one, okay? So based on all of that, let's define an effective obesity management strategy. And even if you're dealing with athletes and you're dealing with performance, it's still a value. This whole system still works very well. No matter how invested you are as a runner or a rugby player or whatever it may be, you still need that cognitive behavioral therapy, removal and replacement. Yes, it may be a bit easier, but there are plenty of athletes that desperately desire success, and they're still human. So we've got to support them on a regular basis, whether on the athletic side, performance side, or on the obesity side. Just a little take for performance, and this is something we do in the US quite a bit. In America, everybody's looking for a performance advantage. So they're all taking what they call PEDs, performance-enhancing drugs. The Lance Armstrong, the Barry Bonds, those guys. It might be Alex Rodriguez, steroids, blood dope, whatever it may be. Everybody's looking for that edge, trying to make it legal. But almost every one of them is on what I call a PRD, a performance-reducing drug. Carbohydrates. Okay? You get rid of the carbohydrates from your life, and your performance is going to be so much better. Okay, so I don't think that using pharmaceutical surgery devices as a multimodal and sequential therapy when your patients are struggling is that harmful. So not only am I asking you to get your head around the carbohydrate side of things, I'm also asking you to get your head around some of these things that are of value with very little harm. And use that equation to be the to have discretion. How much value is there versus how much harm is there? We failed. We've screwed up many times. And I think Prof. Noakes is about to tell us in a wonderful, wonderful way how he did that. But the difference is he looked at things and he came back with a vengeance. And that's why we're here today. So every one of us needs to have a little bit of truth and reconciliation in what we think. Thank you very much.